And hi everyone. I see some familiar faces and familiar names. So glad to be here today. I hope that we have a very interactive and informative session today. So with Erica, the way that we decided to do this session is that I will give you guys a very short presentation on treatment of early stage breast cancer hormone receptor positive, but we will keep this session interactive. So after that, I would like to hear your questions and take it from there. So let me share my screen with you. Okay, Erica, can you see my screen well?
Yes, I can. Perfect. Thank you.
So, what are the subtypes of breast cancer? So, we subclassify breast cancer based on what receptors are on the surface of breast cancer cells. And you probably have heard these receptors. They are including estrogen receptors, progesterone receptors, and HER2 receptors. The estrogen and progesterone receptors together, we call them hormone receptors. So depends on whether the cancer cells express any of these receptors, the treatment will be different. So if any of these receptors are expressed on the cells, we can actually target them with an anti-estrogen progesterone medication or with an anti-HER2 medication. But if none of these receptors are expressed on the breast cells, then we call the cancer triple negative, which the treatment is different and mainly chemotherapy. There is no targets to use targeted therapies. So the chance of a breast cancer be hormone receptor positive is about 70 to 80%. This is the most common subtype of breast cancer. The mainstay of the treatment is what we call it endocrine therapy or hormone blockage therapy with or without chemotherapy. Not everyone with a hormone receptor positive breast cancer requires chemotherapy. What are the factors that considers to see whether a patient benefits from chemotherapy or not? Age is a factor. The size of the cancer, whether the lymph nodes are positive or negative. And the most important thing is the category of test called genomic assay test, that there are two tests in the guidelines, FDA approved, Oncotype DX and Mammoprint, that basically tell us whether a cancer is chemosensitive and requires chemotherapy or not. So what are the key agents for endocrine therapy or hormone blockage therapy? We have tamoxifen and class of medications called aromatase inhibitors. There are three medications in that family: anastrozole, letrozole, and exemestane. You might have heard about ovarian function suppression. That's also a form of endocrine therapy. That is being given in addition to tamoxifen for further hormone suppression for premenopause patients. There are two ways that we do this. Reversible way of ovarian suppression, which is injections with Lupron or Gozerlin. This is more appropriate for younger women who wanted to have more hormone blockage for breast cancer, or the permanent way, which is surgical. This is more appropriate for women who are closer to time of their menopause. So they will do bilateral oophorectomy. So who can get this endocrine therapies? Tamoxifen is approved for both pre and post-menopause patients. So all breast cancer patients are candidates for tamoxifen. Aromatase inhibitors are only approved for post-menopause patients. And that's basically because difference in mechanism of these medications suppressing the hormones. Tamoxifen is a hormone receptor blockage. So regardless of ovaries working or not, it suppresses the receptors of that hormone at the cell level. Aromatase inhibitors are decreasing the production of estrogen and progesterone, and they cannot suppress the ovaries production. What they do is that in our body, ovaries are not the only source of hormone production. In fat cells, the other hormones can convert to estrogen and progesterone. So aromatase inhibitors suppress that conversion. So in order for them to work, ovaries has to be already suppressed, either with the natural menopause, with surgery, or with those injections that we call them ovarian function suppression. So for the patients that we offer them ovarian function suppression to be able to use aromatase inhibitors, these are premenopause women that are diagnosed at very young age. So we know that the younger a patient is, the cancer is more aggressive, higher chance of recurrence. So we wanted to enhance their hormone blockage. The women who don't have a low risk recurrence breast cancer, for example, if their breast cancer is large, or the lymph nodes are positive, or they have other characteristics of high risk cancer on their pathology. And premenopause women who are a candidate for a very new medication that has been approved by FDA just recently, it's called ribociclib or Kisqali. We will touch on this medication in a few minutes. And this is additional medication on top of aromatase inhibitors or tamoxifen that patients with early stage breast cancer can take to further decrease the risk of recurrence. And this medication cannot be combined with tamoxifen. So if a premenopause woman is willing to go on ribociclib or Kisqali, the only choice is to put that patient on ovarian function suppression, change the endocrine therapy to aromatase inhibitors, and then give the ribociclib. So what is the way of taking these medications? Tamoxifen and aromatase inhibitors are a pill that you take it daily. The ovarian suppressions are injections that can be given every 4 weeks. This is the most common way that we do, but they can be given every 3 months in a larger dose as well. Why you should take hormone blockage medications after diagnosis of breast cancer? Because it decreases the risk of recurrence by about 50%, and it improves the survival from breast cancer. How long you should take the endocrine therapy? And that's the, I would say, most common question that we get in the clinic, that how long I should take this medication. You hear it 5 to 10 years for tamoxifen and aromatase inhibitors, but that's a long time difference between 5 to 10. What is the appropriate time of the endocrine therapy, duration of endocrine therapy for you? Initial studies looked at the 5 years of endocrine therapy, and they proven that taking 5 years of endocrine therapy decreases the chance of a recurrence by more than 50%. And that's why initially we were saying patients that 5 years of endocrine therapy is the duration of your treatment. But later investigators thought that how about we continue beyond 5 years, what happens? Do we have some extra benefit if we continue beyond 5 years? So they designed these clinical trials that divided patients to two groups. One group took the endocrine therapy for 5 years. The other group took the endocrine therapy for about 7 to 7.5 years. And they monitored these patients for a long time and looked at the incidence of recurrence of disease. And they found that extending the endocrine therapy beyond 5 years and up to 7 to 7.5 years improves, decreases the recurrence risk slightly, about like a 3 to 4%. But this decrease in the recurrence rate was more pronounced in the late recurrence. What does that mean? With breast cancer, we know that the highest chance of a recurrence rate is in the first 5 years, but hormone receptor positive breast cancers can tend to come back years after the diagnosis, 10, 15 years after the first diagnosis. So this extended period of endocrine therapy helps to decrease the risk of late recurrence of disease 10, 15 years after the diagnosis. So younger you are, more benefit you get from this extended endocrine therapy, because there is a highest chance of you see that recurrence late during your life. How about ovarian suppression? How long we give ovarian suppression? My honest answer is that the data on optimal duration of ovarian suppression, we really don't have a good data on it. The initial clinical trials used it for 5 years. There was one trial that used it for 2 years. They still saw the benefit. Didn't compare the 2 years to 5 years. And we do not have any data on continuing ovarian suppression beyond 5 years. So we usually say about 2 to 5 years of ovarian suppression depends on patient's tolerance and how high risk the disease was. So what are the side effects of endocrine therapy? One thing that I always tell patients that we talk about these side effects, but it doesn't mean that every side effect happens for each patient. These are all possible side effects that we want you to be aware of. But endocrine therapy can have side effects on multiple organs. For example, it can decrease it can worsen the rate of bone density loss and cause osteopenia or osteoporosis. One of the most common side effects of endocrine therapy is musculoskeletal pain, joint pain, achiness. Fatigue is common. So many patients complain of brain fog after starting on endocrine therapy. These are the hormone blockage medications. So all the side effects, symptoms of menopause, you may experience it again, like hot flashes, night sweats, mood swings, vaginal dryness, insomnia. They can worsen blood pressure and cholesterol. So we usually monitor those as well. We can touch base on how we manage the side effects of endocrine therapy. Usually for those patients that have lots of hot flashes and vasomotor symptoms, the simplest thing that patients can do is taking vitamin E, 400 international unit. It has shown that it sometimes can help with the side effects. But if that doesn't help, then there are medications from family of anti-anxiety medications like Effexor, or from family or medications like gabapentin. They are approved for other reasons, but they have proven that they can help with vasomotor side effects of endocrine therapy. So they can be used. For joint pain, activity is the key, and you might have heard this from your oncologist. More active you are at baseline, better chance of tolerating these medications without joint pain. But yoga has proven that it can help. Water exercises like swimming and water aerobic has proven that it can help. And in some patients, they have tried acupuncture, and acupuncture also has been helpful for this side effect. Vaginal atrophy is one of the side effects that has been talked about it less, but more than 40 to 50% of patients experience worsening vaginal dryness. We usually wanted to avoid any hormonal use, hormonal treatments for treatment of vaginal atrophy with hormone receptor positive breast cancer. So any systemic hormonal therapy is an absolute no when you have a diagnosis of breast cancer. We usually try to use non-hormonal ways, and the best way to treat the vaginal atrophy is using vaginal moisturizers. These are vaginal suppositories that you can use it 3 to 5 times a week, and lubricants when there is an intercourse. The moisturizers that have vitamin E in it are the best to work. But there are a percentage of patients that, regardless of how much they take the vaginal moisturizers, they still have lots of symptoms from vaginal dryness, including pain, irritation, urinary frequency. If a patient uses vaginal moisturizers and all the non-hormonal ways and still the symptoms are not under control, in that circumstances, we are okay with the lowest topical dose of vaginal estrogens that can relieve the symptoms. There was a Danish study that included 8,000 women with history of breast cancer, hormone receptor positive, and the use of topical estrogen, not a systemic estrogen, but use of topical estrogen did not lead in worsening overall survival or increasing risk of recurrence in patients who had the history of hormone receptor positive breast cancer. For that reason, now the oncology guidelines allow patients to take topical estrogens, the lowest dose possible if non-hormonal way of treatment of vaginal dryness has failed. But one thing that we have to consider is that in that study, the subset of patients who still were on aromatase inhibitors, they had a slightly increased risk of recurrence. So we can safely say those who are not on endocrine therapy had the diagnosis of their breast cancer a long time ago, but they're not taking endocrine therapy, can definitely benefit use topical estrogen. But we have to be cautious about those who are still on endocrine therapy, including tamoxifen and aromatase inhibitors. What about the newer drugs, CDK4 inhibitors? You might have been seeing the ads about Kisqali and Verzenio that have been recently approved for hormone receptor positive breast cancer. So what is a CDK4 inhibitor? CDK4/6 is a protein on cells. Every cell has this protein. what it does is that it enhances cells growth and multiply. In the cancer cells, this protein overexpress. So cancer cells grow and multiply in much faster rate than normal cells. So the concept is that if we inhibit this protein that causes the cell growth, we can decrease the growth of the cancer cell and prevent the cancer cells from multiplying and spreading. There are 3 medications that have been approved: Kisqali or ribociclib, Verzenio or abemaciclib, and Ibrance or palbociclib. Out of these 3, only the first 2 are approved in early stage breast cancer. Verzenio was the first medication that was approved by FDA in 2003, and then Kisqali got its approval in 2024. Not every earlier stage breast cancer is a candidate to take Verzenio or Kisqali. But if you have a large tumor, pathology high risk, or lymph node positive, there is a good chance that you will be a candidate to take CDK4 inhibitor in addition to endocrine therapy. In the studies, Verzenio and Kisqali had another 25 to 30% risk reduction in recurrence of the disease, patients who took these medications. How about overall survival? Did these patients lived longer taking this medication? That data we don't have yet because these are new medications. So we need to follow these patients for a longer time to see whether there is any survival benefit from taking these medications or not. But so far we know that there is decreased risk of recurrence, about 25 to 30%, in addition to the 50% risk reduction that endocrine therapy has. Both medications are in the pill form. Verzenio is a twice-a-day medication that is being taken continuously for 2 years. Kisqali is a medication that is being taken in 3 weeks on, 1 week off, once a day, and the duration is for 3 years. Both medications has a little bit more side effects if you compare it to endocrine therapy, including they can suppress your bone marrow, causing low blood counts, increasing the risk of infection. They require more close monitoring of blood counts, kidney function, and liver function. They're causing more fatigue. So decision on whether you are a candidate to have additional medication, additional of CDK4 inhibitor on top of endocrine therapy is usually depends on how high risk is the cancer, what is the risk of recurrence, how high the risk of recurrence is, and then your goals of how much you're able to tolerate the side effects, how old are you, and it will be a mutual decision by your between you and your oncologist whether Kisqali and Verzenio is a good choice for you. With this, I wanted to stop and open up to the questions to see what questions you guys have.